So welcome everybody to tonight's webinar, Is Your Pelvic Floor Telling You Something? We're so excited to have all of you here with us this evening. And we know there's still a few folks who are probably just joining us as we are just past the top of the hour. I do want to go over a few administrative things before we get officially started. So it's a great way to kind of give everybody another minute or so to get on. If you would like to pose a question to our panelists, please use the Q&A feature in your Zoom room. The chat is also available. However, it is a little bit easier for us to manage a lot of questions coming in if we can have those in the Q&A section. So again, please try to use the Q&A section on Zoom to submit any questions that you may have. That being said, please note that we are not able, and Alana and Uma are not able to give kind of individualized advice, diagnoses, things like that based on your individual condition. Unfortunately, it's just we're not able to do that as regulated healthcare professionals in a format like this. So please try to keep your questions, if you can, kind of more global or more broad so that we can help to answer them as best as we possibly can. However, if you have a specific question, we do have a couple of other clinicians with us moderating our chat that will be able to help you to find a clinician that may be able to help you with your individualized question. So again, just trying to remember, use the Q&A wherever possible and rather than the chat. And we will try to keep our conversations to more kind of global concepts. We cannot give you individualized advice. In this webinar format as well, you are not able to turn your camera on. So I know a couple of people were asking in the chat, should I turn my camera on or off? Participants are not able to turn their camera on. You will only be able to see us in terms of our cameras. We will have some open questions towards the end after we get through our frequently asked question component that we have got pulled together for you here today. And at that point, if there is a verbal question that you would really like to ask, you can certainly raise your hand at that time. Right now, we won't be inviting anyone to kind of open up into the chat at this time. So again, we encourage you to use the Q&A to type your question wherever possible. It will help us to manage with the big number of people that we have on the line with us tonight, and we will go from there. So before we get started into the actual kind of presentation today, I'm just going to stop sharing my screen now. I just want to begin with a land acknowledgement. The Lifemark Health Group team acknowledges that our work spans many territories and treaty areas, and we are grateful for the traditional knowledge keepers and elders who are with us today, those who have gone before us, and the youth that inspire us. We recognize the land and the benefits it provides all of us, and we invite everyone to reflect on the past and present history in their particular geographic area, and for us each to think about what we can do to work towards reconciliation. Now, my name is Krista. I will be your moderator today. I am a physiotherapist as well by background, but certainly this is not my area of expertise of practice. So I have some of our lovely, very knowledgeable clinicians with us tonight that will be our panelists, and I will be kind of leading us through the questions that we put together for you and also moderating the chat. As I mentioned earlier, we do have a couple of our other clinicians monitoring the chat as well to try and help to answer any questions that you have. So again, feel free to put those in now. They're going to be flagging the key ones for us to take a look at towards the end of the presentation as we go along. Okay, one last reminder, please use the Q&A rather than chat with your questions so that we can keep an eye on those. I have the pleasure of introducing to you our two panelists tonight. First, I am going to introduce Uma. So Uma Ghosh is a physiotherapist and one of our pelvic health leads here at Lifemark. She graduated from the University of Toronto with a Bachelor of Science in Physical Therapy in 2003 and completed a doctorate of physical therapy at Boston University in 2010. Uma began treating clients with pelvic floor dysfunction secondary to oncological, sorry, I have a hard time with that word, intervention while working in New York at Memorial Sloan Kettering Cancer Center. Since relocating to Toronto, Uma has dedicated her efforts to treating women and men with pelvic floor dysfunction. She currently practices at Lifemark, Leslie and Shepherd in North York in Ontario, and coordinates the pelvic health curriculum as an adjunct lecturer for the University of Toronto Physical Therapy Department. Second panelist that we have is Alana Devlin. Alana is also a physiotherapist and pelvic health clinical lead here at Lifemark. She obtained her Bachelor of Medical Rehabilitation in Physiotherapy from the University of Manitoba in 1996. She became a certified manipulative therapist in 2002 and began to pursue further advanced education in her passion for women's health. She has engaged in advanced training throughout Canada and the US. In 2018 and 19, Alana successfully obtained the Certificate of Achievement in Pregnancy Postpartum Physical Therapy and the Certificate of Achievement in Pelvic Physical Therapy through the American Physiotherapy Association. Alana completed her doctoral degree in physical therapy in the summer of 2021. Made great use of that pandemic time, Alana, great job. She's proud to be an instructor and teaching assistant and work alongside gynecological and urogynecological health professionals. So really excited to have all of you here. Good afternoon, good evening, no matter where you are in the country, and we are going to jump right into things. So my first question I'm going to pose to Uma. So Uma, what I'd like to have you do is just kind of start us off by level setting all of us. Tell us, what is the pelvic floor, what it does, why it's important, and kind of what is pelvic floor physiotherapy?
Thanks, Krista. That's definitely a good place to start with our talk today. So I just want to say before I answer that question that the way I'm going to answer this question is going to be specific to pelvic anatomy, female anatomy, male anatomy. Alana and I are quite aware that gender is a very fluid concept and that there's a whole spectrum. And we're happy to address any questions surrounding that later on in the talk. But how I'm going to answer this question for this part of the talk is going to be specific to anatomy specifically. Okay, so let's get into it. So this is a pelvis, and this is kind of what it looks like from the bony aspect. And everything that we see in red from the inside and the out is part of the pelvic floor complex. So these muscles are designed in layers. So this layer right here kind of sits externally and is sitting on top of the bones. And because they are superficial, we can access them from the outside. So this is very easy to be testing from the outside. We have a middle layer of muscles, which unfortunately is not really visualized on this specific model, but those muscles have a role to play in the sphincteric control for the bladder and for the urethra. And then finally, our deepest layer of muscles in here, and hopefully you can all see this, but attaches to the back of the pubic bone and it wraps all the way around and attaches directly to your tailbone. So these muscles are really, really deep inside the pelvis. They're like a bowl. They attach from front to back and side to side. And those muscles, because of the depth of where they are found, can only really be accessed from the inside. If there was an external way we could test that, I'm sure that's what we would be doing, but unfortunately that's not the case. So, and I'm sure you've noticed that this is a female pelvis. Well, males also have pelvic floors. And so to show you kind of the difference between the female and the male pelvic floor, this particular muscle right here that's underneath the labia for men is actually midline from the testicles up down to the rectum. So aside from that one difference, pretty much all the other muscles are pretty much the same. So fun fact, men also have pelvic floors, and we are going to be including you guys in this talk as well. This is not just a female specific problem. Now, as far as what the jobs of these muscles are, I like to kind of call it the 5 S's. The first job that these muscles perform is for stability. They stabilize the joints of the pelvis, and they also are part of the inner core unit, which is the foundation of our bodies and also keeps our bodies nice and strong. The second thing that they do is they provide support. So they're kind of providing a nice little house for all of our pelvic organs and making sure that they're nice and supported within that house. They also provide a role to play in sphincteric control. So it keeps us continent of feces, of urine, of flatus. And so that sphincteric role is obviously very important and probably a lot of what we're going to be talking about today. And they also play a role in sexual appreciation. So all those yummy feelings that we have with sexual pleasure and orgasm are a big part of what these muscles play a role in as well. So obviously we want to keep those muscles nice and happy. And of course, finally, they play a role in circulation. So we kind of call that like a sump pump. So it helps to kind of pump out all of the circulation of the fluids in our pelvis. So 5 roles, and very, very important roles. And of course, when our pelvic floors are unhappy, they're going to speak to us in probably more than one of those areas. And so it's not coincidental when we start to kind of get clustering of things kind of going sideways in any one or multiple of those roles. And Alana is going to get into that with a little bit more detail. So that's pretty much all of the roles of the pelvic floor. Now, as far as pelvic floor physiotherapists, generally speaking, we are orthopedic therapists. We are, very skilled at looking at the whole entire body. But the one thing that kind of distinguishes us from orthopedic therapists is that we are specifically trained to perform assessments as well as treatments of the pelvic floor muscles. And that generally means an internal examination of the pelvic floor, which we have taken postgraduate courses to make sure that we are highly trained and highly competent to be performing. Physiotherapists are a small number of healthcare individuals who are mandated to perform that type of assessment and treatment. And we are highly regulated by the College of Physiotherapists to make sure that we are competent and highly skilled and highly trained to perform this type of evaluation. So really that's the one distinguishing factor between pelvic health therapists and orthopedic therapists, but we are kind of under the umbrella of orthopedics with a special focus to be able to perform this one specific skill.
Amazing. Thanks so much for that, Uma. And I love the 5 S's. It kind of helps me to remember those 5 kind of key functions. And I put them in the chat for everybody so that it would be easier for them to write those things down. I had some spelling challenges, I think, on sphincteric control, but no judging at this point. But thank you for that. I think that's really a good way for us to be thinking and understanding what our pelvic floors do. So Alana, I'm going to go over to you now. And can you maybe tell us, like, how would we know if there's an issue with our pelvic floor? So how might my pelvic floor be trying to tell me something, as we kind of highlighted as the topic for tonight?
Well, I guess the first thing we know is that our pelvic floor may be trying to tell us something if we know what's normal and abnormal. And that's one of the problems in general women's health, is that we're really never given a venue to learn about what's normal and abnormal. So this is where I want people to take out their pens and pencils, because this is kind of where you'll find out if you should be going to see some healthcare provider who's specialized in pelvic health and who's knowledgeable. So that is sometimes challenging to find because not everybody is truly knowledgeable in it. But these are kind of the take-homes here. So Uma liked the 5 S's, and I like the 4 P's. So if you think of, there's 4 things that I always like women to know that are kind of that function with all of those different functions that Uma talked about. So if you have problems with one of those, they'll show up in usually one of these ways. So the first letter P has to do with peeing or your urinary function. So you should be in full control of your urinary function all the time. There's different types of incontinence or involuntary loss of urine. So one type of incontinence we're talking about already in the chat about is stress urinary incontinence. So that doesn't mean you're stressed out. That means that you're adding stress from the outside of your body to your inner core unit. You're laughing, you're jumping, you're coughing, you're sneezing, and your body isn't able to control that pressure. And so it fails at controlling the pressure, so you end up leaking. The other type of common urinary incontinence, there's other types, but these are the 2 most common types, is urge urinary incontinence. That's one of the ones where you're like, oh my goodness, I need to get to the bathroom and I need to get there now. And you get these huge involuntary contractions of your bladder that give you that overwhelming urge that you have to pee, and many people don't make it to the bathroom. So that's also a really other common thing that can happen. So peeing, you should be able to control it, but also I don't want people having a hesitation to pee. Some people who have pelvic floor dysfunction will sit down and they really have a hard time initiating that stream. So that's another thing that we look at sometimes as somewhat of a problem. So that's when it comes to peeing. Next P, as you guessed it, it's pooping. So pooping generally, or your evacuation of your bowels, often people with pelvic floor dysfunction will have one of two problems on opposite ends of the spectrum, believe it or not. And we'll talk a lot about why that is later. So one is that some people may be chronically constipated from the time they're kids, or just constipated since they've gotten older. So it's kind of like they can have a constipation, a hard time evacuating fully their bowels. And then the other one is that sometimes you'll have a difficulty holding in bowel movements or bowel contents or gas. So if you really have a hard time controlling your gas, that might tell you you've got something going on with your pelvic floor. And since we're just talking about urine and bowels right now, it's really important for women to know what is normal, because this is what I find so many women don't know. So normal peeing, you should be voiding urine between every 2 to 4 hours normally, and you should not be getting up to pee most times during the night. So normal nighttime voiding should be 0 to 1 time a night. That's normal. And a lot of people are like, oh my goodness, I pee every hour, or I'm up 3 times a night. That's your pelvic floor trying to tell you something. So that's one thing. When it comes to bowel movements, normal bowel movements can range from 3 times a day. That's totally normal for some people, to 3 times a week. That is also totally normal for some people, and it depends on what's coming down the tubes at the same time. We like people to have soft form stools. They shouldn't be watery. You shouldn't be, having any kind of like meatball-y type things. So this is another thing that can kind of cause pelvic floor dysfunction, but also be related to pelvic floor dysfunction as well. So that's your first P is pee, next P is poop, next P is pressure. So I don't want people to, they can't do a lot of activities because they have this feeling of a pressure or a weight in their pelvis. Sometimes even after you have a bowel movement, you may feel like there's actually tissue protruding sometime. That can be called a pelvic organ prolapse. We can talk about that later. Very common in women. Women don't understand how common it is. It's up to 50%, if not higher, in a lot of women. So it's by no means abnormal. We just don't talk about it, as we don't talk about many of these things. So that's prolapse. And then the last thing is pain. Pain is not a good thing. I don't want people to ever have pain with intercourse, despite what our society has traditionally told us. Women should not be having pain with intercourse. Men should not be having pain with intercourse. Men should not be having pain with voiding or with erections. That's a pelvic floor dysfunction often. Pelvic pain in your pelvic girdle and the bones that are surrounding your pelvis. Often that's an issue with your pelvic floor. And for a lot of people who are having, I saw somebody today, they have low back pain, they have hip pain, they've been to every practitioner, they've been to chiro, physio, massage, they've, had all of these tests done and nobody can find this answer. Quite honestly, sometimes it's like the missing link is your pelvic floor that a lot of people don't realize. So those are really my 4 Ps of how your pelvic floor is trying to tell you something. And again, like a lot of these problems are extremely common, much more common. We'll talk about that later also, but it's not normal to have any of those 4 Ps that are not under your control.
Amazing, Alana. Thank you. And again, I really like the letters helping us to kind of remember these things. So I, again, put the 4 Ps in the chat too. So peeing, pooping, pressure, and pain, along with Uma's S's in terms of the function. So thank you both for those kind of great tips. So Uma, I'm going to go back to you. And, Alana kind of said a little bit this about how these kind of problems are quite common, maybe not talked about or acknowledged as much as we might want them to be, which I hope you'll address as well. But how prevalent are pelvic floor conditions of various different types? How common are they in our society?
Yeah, that's a great question. I think if you have a television and you watch TV, I think we are all seeing how prevalent things are, because we're bombarded with all sorts of commercials for various incontinence products nowadays, right? So I think we do know on some degree that, yes, these are extremely common and prevalent issues. And as Alana said, they're common, they're not normal, but more importantly, they're treatable, right? That's what we really want to have is like our take-home message today is all of these things are treatable. So if we are going to kind of talk about some statistics now, in terms of urinary incontinence, 3.3 million Canadians experience urinary incontinence. That's 10% of all Canadians. And that's honestly just what's reported. I'm sure that's completely an underreported number. I'm sure the numbers are way higher than that. But just by sheer numbers, like that's just an incredulous number. As far as pain goes, statistically, 1 in 4 women will experience pain, pelvic pain in their lifetimes. 1 in 3 men will experience pelvic pain in their lifetimes, which is also quite a shocking number, because you would think that the numbers for women would actually be higher than men, but actually it seems to be more percentage of men experiencing pelvic pain issues as well. In terms of institutionalization, incontinence is the #1 reason why caregivers have to institutionalize their family members, because the burden of taking care of someone in your home who's incontinent is exceptionally high. So #1 reason why that happens. And this is the most horrifying statistic of all, I would say, is that 50% of us are going to end our lives in diapers. And that's just mind-boggling if we think about that statistic. 50% of us, 1 in 2 people. So extremely prevalent issues, very, very common, absolutely not normal, and absolutely treatable. So that's kind of what we want to drive home today, is that if you're experiencing any of these things, absolutely there's help and you should seek it out.
That's great, Uma. Can you maybe just talk briefly, just a little bit more kind of focused on the men? Sometimes they get lost in this conversation a bit. I know you had mentioned to me ahead of time about prostate surgical procedures and kind of the role for pelvic floor physiotherapy. Can you just address that really briefly before we move on?
Sure. So men who undergo prostatectomies, the prostate happens to anatomically sorry, let me back up a little bit. The urethra for men happens to run directly through the prostate. And so when they remove the prostate for prostate cancer, it's virtually next to impossible to not be able to remove that prostate without some level of damage to the urethral sphincter, especially the internal one. And so the biggest complication that often happens with men after prostatectomy is that they do develop incontinence, which is something that obviously is absolutely treatable. It can be more significant if they have to undergo radiation treatments in addition, because now we're introducing scar tissue and radiation fibrosis into that picture and mix as well. And it can be pretty life altering, because it really stops you from being able to do regular everyday things, even something simple like going to do grocery shopping. So this is absolutely treatable. And what I often explain to men when you take out the prostate is men are lucky. They've got sphincters that control everything, right? So if there's pressures that are coming down, it's not going to come down and out through your pelvic floor, because you have sphincters that are going to hold everything together. So men tend to leak their pressures out through the front in the form of hernias, or out through the back in the form of disc herniations. But essentially taking the prostate out, it's like we're creating a vagina for you. And if there's going to be pressure that's going to leak out, it's coming down out through the pelvic floor. And so things that may have been hidden by the fact that pressures were controlled by the sphincters, that's really going to get highlighted by the fact that now all of a sudden we've created this nice little space, and on top of that, damage that internal sphincter as well. So men for sure can really benefit from pelvic health physiotherapy to teach you how to sort of control those pressures, how to get your breath pattern working better, how to improve your posture so that you can get that connection with the inner core and prevent and hopefully resolve, if we can, some of those incontinence issues.
Great. Thank you for taking the time just to explain that, because I think, again, it's not an area that a lot of people think about or realize. I think, some of the physicians are getting a bit better about recommending physiotherapy related care around that, but definitely something that some of our patients or individuals out there might be interested in. Okay, so Alana, I'm going to go back to you. So, so far we've talked about kind of what the anatomy, the function is, what it looks like when you have a problem, that it's pretty common, not normal, and treatable. Good takeaway message. If I come for an assessment with a pelvic floor physiotherapist, what should I expect? Because, I think some people get a little bit nervous around this, and I think we can all admit that, especially us women, don't particularly enjoy going for our PAP test or going to the gynecologist. It's not a fun thing to have happen. But tell me what to expect if I come to see a pelvic floor physiotherapist.
So that is a question obviously we get asked often. And you have people just coming in sweating that they're so nervous about this exam. So first of all, right now within our company, we have female therapists. So there are some male, very few, but some male pelvic therapists that do exist. And if anybody would feel more comfortable with that, I'm happy to help them seek those people out. But so generally it's a one-on-one. It's just the two of us talking about all of this intimate stuff where you are in a private room. It's not the curtained off rooms like you normally see in physio. So you're in a hard-walled private room with a one-on-one female physiotherapist. That's what I always tell people. That's number one. So your privateness is kept private because these are kind of sensitive topics that we're often talking about. The other thing is just be prepared to do a lot of talking. People are shocked at how multifaceted a lot of their pelvic floor complaints can be. So we will look at your entire history, what medications you're on, what previous surgeries you had, what previous problems you may have had that are really even, you don't even think they're related, but they are in fact related. So it's a lot of talking in terms of a history. Then, if you consent, that's the most important thing for people to understand. You are always fully in control. This is your body, this isn't ours. So only with consent will we even start an external physical examination. Some people just want to come see me the first time to build up rapport and make sure that they can trust me. And then that's where we stop, because this is your appointment, not mine, again. So it's with consent, we'll go on to look at the external parts of your body. We'll go on to look at your posture, your breathing patterns, maybe some of your alignment or your leg lengths or how your foot position is. It's very comprehensive. So that's kind of where that will start. And then only again with ongoing consent will we move on to do any type of internal assessment. If need be, and somebody is really, really, really apprehensive about having no internal assessment done, there are things we can do externally. So I don't want that to limit people from coming, is they just can't fathom the idea of an internal assessment. So we can do things externally. We can do a lot of education. That's a ton of what pelvic therapists do for sure. But with ongoing consent and very slowly, without any speculums, we don't use any metal instruments. It's just a gloved hand that goes and examines your internal pelvic floor musculature. So as Uma was saying before, that is the best way really to see what's going on. And people usually find it very enlightening. People leave thinking they've learned so much about their body. So that's the big thing, because we really want to feel not just if your pelvic floor muscles are weak. That's not a problem often. Often it's tightness, or it's tenderness, or it's lack of movement in one of your joints. We'll assess your tailbone usually through your pelvic floor if that's a problem. But it's really important to get that internal exam, because we want to individualize treatment to you. Because as Uma will talk about a lot, it's not just about telling people to do Kegels. We know if I give somebody that verbal cue alone, that's usually not enough. And so that's usually what a treatment will look like. You're draped, you're covered. It's very, very modest.
Great, thanks, Alana. And you're right, because I really like how you really kind of knocked home that it always comes down to the individual. And if you say yes to an internal examination and then you start and you decide to change your mind, that's okay too, right? You have, as the patient or the individual coming for care, you have that right. So please do not ever feel like you must do anything in any care, any sort of medical environment, but particularly, coming to one of our facilities or for pelvic floor physiotherapy, you can change your mind. You can decide yes and then no, and then next time you come, no, I wasn't comfortable. That's okay too. And there's so much you guys can do without doing that internal if that's what's required. So thank you for sharing that. So Uma, I'm going to throw it back to you. So Alana covered the assessment. Can you talk to us a little bit about what treatment might look like? So I know there's lots of different sorts of conditions, and it would take us all night to go through each and every type of condition. And even so, the individual factor of that will make it complicated. But can you tell us a little bit about like what it might include?
So the treatment will basically be based on what the interview portion and what the assessment tells us. So that assessment, as Alana went through in great detail, is basically what we kind of jump off or use as a jumping off point to create a treatment program. So once we've listened to your story, once we've understood what your issues are, once we understand and determine what those goals are for your treatment program, that helps us kind of dictate and put together a program. And again, treatments don't have to be internal. They can definitely be external. There's a lot of external stuff that we can do, ranging from looking at your breathing mechanics and looking at your posture, looking at your movement patterns, because life, of course, is not static, it's dynamic. There's a lot of stuff that we're doing just with everyday movement patterns, picking up your kids, dragging the garbage cans to the curb, like things like this. So once we kind of hear what those issues are, we can start to put together different exercises or different strategies that you can kind of use to address whatever those issues are that are causing you those issues and causing you those problems. Now, other external things that we can also take a look at. So for instance, someone who has pain issues, we might be interested to do some connective tissue release, or we might be wanting to do a little bit of stretching of muscles, or trigger point releases. These are kind of things, like standard things that we do as physical therapists in the orthopedic world. And so pelvic therapists are doing that as well. Like we're also, like I said, we're orthopedic therapists first and foremost. And so there's a lot of releasing of tissues that we can do externally, and specifically scar tissue, C-section scars, and appendectomy scars, like whatever scars we see basically from your ribs down to your pelvis. We're interested in all of that. We want to release all of those things and also see if there's something that's driving your symptoms based on those scars. And then, of course, we do perform things internally as well. So if you've got pelvic pain issues or pain with intercourse per se, we want to see what part of the perineum and the pelvic floor are actually causing those specific issues. And we're going to go through how to desensitize these things, how to use our coping mechanisms for pain, how to use mindfulness, and how to desensitize as we're providing certain stimuli and allow your nervous system to kind of diminish some of those pain responses, so that we're able to get you to a point where your pain is controlled well and hopefully resolved. So everything basically from external regular physiotherapy types of things, ranging right over to specific pelvic floor muscular techniques, is the full gamut of what can be created as a treatment program. And of course, we provide you with things that you're supposed to do for home as well. And so those are things that are meant to kind of piggyback on the things that we're doing for you, because we're seeing you for, I don't know, an hour, half an hour, one time a week, and then you have the rest of the 6 days of the week that you have to do some stuff. So you'll be given home programs that can range from, again, mindfulness and breathing strategies, coping strategies for pain, exercises, training and strengthening for, if it's hip strength or pelvic floor specific strengthening. All of that can be encompassed in a home program that's meant to help you carry over some of those things that we do in sessions.
Awesome. Thanks, Uma. And I know that you've also, and I don't think you touched on it, was just around other like lifestyle modifications. And I saw somebody just recently put in the chat about like whether caffeine or other supplements can be a factor with bladder frequency. So I don't know if you just want to talk very briefly about the like lifestyle modification stuff that can be quite helpful, and maybe specifically about this kind of caffeine query.
Absolutely. So yeah, lifestyle modifications are huge. So that can also range not just from fluid intake, but it can range from sleep hygiene. It can range to diet. Like there's lots of different things that we touch upon that you wouldn't really think kind of falls under the umbrella of physical therapy. But if someone is waking up 3 times a night because they have to pee because they've dehydrated themselves all day long, and then all of a sudden they're pounding back water after 8 p.m. at night and losing 3 hours of sleep every time they wake up at night and presenting to me with pain or urgency, yeah, I want to address that, because there's only so much that my heads are going to do for you if you're losing 3 out of 8 hours of sleep every single night because you're peeing. So yes, lifestyle modifications are huge. And so just some quick little tips. I like to cue people as to how to become what I like to call water positive, right? So if you kind of look at everything as like a 1-to-1 ratio, 1 coffee means -1 water, 1 tea, -1 water, 1 Perrier, -1 water. So water is water. You can't really substitute water. And if you are not water positive, then essentially you are not just dehydrated, but there's going to be a diuretic effect that's also going to happen. So you're going to get a double whammy. So, if you're drinking 7 coffees a day, that means you're going to have to drink 7 waters a day to offset that, and then some to become water positive. So maybe you should consider why you're drinking 7 coffees a day, and maybe it's better to drink 3 coffees a day and make up that with water instead. So yes, water is extremely important. It's going to impact your bowels, it's going to impact your bladder, and how you drink that water is going to impact your sleep. So there's like a whole domino effect of things that kind of spreads out from something simple like not drinking water.
Awesome. And I know Alana kind of tweaked this a little bit, but can you just talk about the Kegels? Because I feel like anyone who has ever had a baby has talked about like, oh, you just have to do Kegels. So can you just address the Kegel thing for us? I don't know, Alana, do you want to take that?
Yeah, sure. Okay, I'm going to go back to one thing we were just talking about that Uma was talking about, because in terms of urgency, like the caffeine, we call those bladder irritants. So your bladder is a muscular organ, and so if you're irritating the inside of that muscular organ, you can imagine that muscle, that's your bladder. Your bladder is not just this balloon that empties and fills. It's almost like your bladder is like, get this stuff out of me that's irritating my lining. So caffeine, that's where coffee comes in. Caffeinated beverages, caffeinated tea. The caffeine itself is a bladder irritant, so you're going to have more urgency. You'll have to go more often. You're going to get that overwhelming urge that you need to pee. Hot chocolate, all of that stuff. The other one, big one, and these are just the top 3. So there are other ones, and so some of these affect some people, some of these affect another, but don't affect others, but these are really the top 3. So caffeine, carbonated beverages, for some reason, it's like how the carbonation goes through your system really tends to be a bladder irritant, and alcohol. So some people will realize when they have those glasses of wine, they're running to the bathroom way more often. So that just has to do with that whole caffeine talk in terms of like that bladder irritation, and does that make you pee more? In terms of the elusive Kegel, it is like my favorite question, because I wish that I needed to book off my assessment and treatments with you are an hour. And if I just had to sit here and talk to you and tell you to do Kegels, I would have a really boring job and I probably wouldn't be very busy. So we know now from research, because we're looking at this, that if I just say to somebody, oh, honey, so do some Kegels, most women cannot coordinate a proper pelvic floor contraction with just me verbally telling them alone. Otherwise, we'd be putting up billboards everywhere and this wouldn't be a problem. So we know that it's really difficult to tell these inside muscles. My joke about Kegels or pelvic floor contractions, which is really what they are, is that these are private part muscles. So your exercises should look private. If I can see you bopping up and down in your chair while you're doing it, or you're holding your breath, then that's not private. Your partner can look at you and think, oh, you're doing those vagina exercises again, or you're doing those pelvic floor exercises again. So that's not good. You want to have, so it should be a coordinated contraction with breathing. It's not easy for me to see people from the outside and make sure they're doing this Kegel, which is literally a lift of your pelvic floor, well from the outside. So there's no way for me to really tell. And the other problem is it's not about Kegels. So here, most of the time when people end up in our offices, it's not about that they can't contract. Often it's the fact they can't relax. And that's where Kegels are not for everyone. So it's really, really important to get an individualized treatment. If I could just run classes and throw everybody on these fancy Kegel machines, and wow, that would be easy. But it's not that simple. Everything has to be individualized to where you're weak, what your dysfunction is. Are you weaker, in certain postures? So do you have prolapse? There's all these things that can go on. But many, many times, a lot of pelvic floor dysfunction is caused by a tightness of your pelvic floor. I always like to give the example, there's a contraction and a relaxation. This is a full functional range of motion. This is a healthy muscle. This isn't a healthy muscle. This is a tight muscle that's weak. So you're going to start having problems. So that's why I even hate that word Kegel, because what does it really mean?
Amazing. Thanks, Alana. I knew I would get you up on your soapbox there. So thank you for doing that. All right, one more question that we have, and then I'm just going to let our moderators know if there's any great audience questions that are kind of global that we haven't kind of covered off yet. Please just flag those to me. We'll be ready in a minute. So Alana, still with you. what's the success rate of treatment? So, you've talked a lot about kind of how it can be very helpful. And I actually even saw somebody ask about, could it make it worse? So can you just talk about success rates, and then also anything about side effects that you can kind of throw in there?
Okay, so I'm going to cover a few things because I saw it coming up in the chat, so hopefully I'll get it. But so in terms of pelvic floor muscle training, that means I am trying to get a way for, I'm going to cue you to turn on your brain to get your pelvic floor, these muscles that you can't see otherwise, to try and engage. We know now there's done, if anybody's into research out there, it's called a Cochrane review. It's a very high level review of a lot of research. So now they've determined that it should be first line treatment across the board. There, everybody realizes that pelvic floor muscle training or pelvic floor physio should be a first line treatment in incontinence. So it really should be. So if you think about it, we know there's a massive, everybody thinks, oh God, somebody was asking about cost. It really differs throughout the entire country. And this is a national webinar. So it's different everywhere, but I would say it's generally over $100 or so for sure throughout the country. But when you look at the cost, we looked at they measured the cost of the cost of being incontinent is, and it's about $750 a year out of pocket expenses. That's year after year after year for the rest of your life. That's huge. If sometimes I can change people with even like 2 or 3 visits, that's all they need. So that's a huge cost savings in the end. So that's one thing. And they looked at people. So remember I was talking about those different kinds of incontinence. So stress urinary incontinence, the coughing, laughing, sneezing incontinence. In people who did pelvic floor muscle training, there was about a 74% improvement in that stress. That's an improvement. So that's a cure or an improvement. And in terms of other types of incontinence, because remember, that's not the only type, that's a lot of it is the urgency, like I gotta pee and I gotta pee now, or they can't make it to the bathroom on time. There was a 67% chance of cure or improvement just with pelvic floor muscle training alone. So that's just incontinence. We treat a lot of other things. Pelvic pain has huge benefits. Anybody you're seeing who's a pelvic pain specialist, they will want you to see a pelvic floor physio because it is by hands down one of the most effective treatments for many, many types of pelvic pain. So, and somebody was also asking about prolapse. So prolapse, depending on where you are with your prolapse, is basically your organs are descending. So it's almost like, I call it it's really a female hernia. Men don't tend to get prolapses because they're luckier with their anatomy design. So prolapse is where an organ has descended into a spot that it's not supposed to be in anymore, just like a hernia is. And prolapse and hernia all has to do with a lot of connective tissue integrity from above and the abuse of pressure from above as well. So people who tend to be constipated, holding your breath while you're doing, somebody was asking about, doing chin-ups. If you're like, while you're doing your chin-ups, you're going to get a lot of pressure coming down, and a lot of people will leak, or they'll feel pressure in their pelvic floor. So there is definitely evidence for improvement in prolapse symptoms. Prolapse is never a medical emergency, but if we can improve your symptoms and make it not bothersome and improve your quality of life, then that's great. So definitely, if people have, it's like they're graded by 4. I always tell people it's worth a shot for grade 1, 2, and 3 for sure. Grade 4, really at that point, that's where things are, really hanging out. We call it prostodentia. It's like your organs are outside of your body. That's really at that point surgical, if it's bothering you. But if it's not bothering you, then it doesn't have to be surgical either. And there's other conservative measures. But that's the thing, like your pelvic floor physio is going to know all of these options for you and wrap it up into a nice little package and give you all your options.
That is awesome, Alana. And you know what, perfectly timed, and we couldn't have planted it, but Nanji just posted in our chat saying that they suffered from urinary frequency and finally found out about pelvic floor physio after 25 and a half years. And 1 week, it changed their life, and their success rate was almost 100%. Again, couldn't have planted, couldn't have.
a lot of that is going to be the education you received, like just not to pee just in case all the time. That, that's what we learn as little girls. Oh, go to the bathroom just in case. Or, as your mom is training anybody, little children, oh, we're going into the mall, go just in case. But the problem is the go just in case is a lifetime habit that we end up developing. So that's like, it's just a lot of it is education about what's actually going on in our bodies and what's normal.
Awesome. Thank you. All right. So I'm going to just pause there, and just a friendly reminder. I've said this at the beginning, but in this format, we are not able to give, individualized diagnoses or treatment recommendations. It does require us to conduct an assessment for us to do that from our regulatory requirements and our professional licenses. So any of those kind of questions and comments, and I know one of our therapists has been trying her best to answer as neutrally as she possibly can in the chat for as many of you as possible, but please don't think we're ignoring your question. We just unfortunately can't answer that. We do encourage you to seek out a consultation. If you're not sure about whether pelvic floor physiotherapy is for you, contact one of the clinics. And I know that the girls or the ladies have been dropping that in the chat on lifemark.ca. Find a location and call them and say, hey, I'd like to have just like a quick chat with the pelvic floor physiotherapist just to see if this is right for me. Or like Alana said, come in and just have that first history taking, and the therapist can tell you based on that what they think might be going on and what treatment might look like for you. So please, again, we wish we could answer everybody's individualized questions, but we can't. So I'm just going to ask, I know the chat has been very active and the Q&A has been very active. Andrea or Susie, I don't know if you are able to unmute and tell us if there's any other questions that you think would be great for us to address. Just while they're getting ready there, just let you know we have recorded tonight. We will be sending a link out to all of you as the registrants for this webinar, a link directly to you within a couple of days of this event. You will then be able to share that link with any of your friends or family members who you might be kind of thinking about, or you hear them say something next time like, hey, that's not normal. These girls told us it's common but not normal and it's treatable. You'll be able to share that information or go back and reflect on it as well. We will also be posting a brief summary, kind of in a brief article, a blog type article as well after this event and the next couple of days. So hopefully that you can find that valuable. Andrea or Susie, do you guys have anything you want to bring to the table here?
Yes, I have a few questions that have been asked in the Q&A and the chat specific to prolapse. The question was, would pelvic floor physio help with a grade 3 prolapse? Would it help with a grade 4 prolapse? There's also a question about, would it help prevent a uterine prolapse? So I thought I would pose it to you girls to give a really good answer for these people.
Oh, okay, maybe I'll start and then you can tag on. Okay, so prolapse, just to reiterate, is a pressure system problem. You are basically leaking pressure out through your pelvis in the form of organs. And yes, there are stages, and stage 1 and stage 2 are good candidates for pelvic floor physiotherapy. We get really good outcomes. And again, prolapse is mainly about symptom management, right? And so Alana kind of touched on this a little bit. So the actual presence of a prolapse isn't a health concern in and of itself. It's not going to predispose you to infections or getting cancer or, I don't know, endometriosis. Like all of these things are not going to happen as a result of just the sheer presence of the prolapse. The prolapse is a nuisance more than anything else. It's really, really irritating to have this feeling of pressure in your pelvis all the time, or possible rubbing of tissues if it's really descended down past the introitus of the vagina and now rubbing against your underwear and these types of things. So at that point, and I think Alana had mentioned this already, like stage 3, stage 4, you're probably looking more at surgical interventions at that point, or at the very least possible fitting of a pessary to try to hold everything together and provide some support. But I would say that if you're going to go down the road of surgery, I think there's still value to prehabbing yourself before that surgery, because getting the surgery done isn't going to change how your pressure system operates. You're still going to continuously be pushing pressure down into the pelvis, only now your pelvic floor is going to be in a state where it's been disrupted. There's scar tissue. It may actually be a little tighter than it used to be. And I like to kind of use the analogy of a trampoline to explain how the pelvic floor kind of works. It needs to be elastic and provide some recoil and support. And if you take a trampoline and you ramp it up and make it nice and tight and short, but you continue to jump on it, you're either going to break your legs or you're going to break it, or you're going to rip a hole right through that trampoline. So that's essentially a situation of needing a revision. You're going to have reoccurrence of whatever's left to prolapse, which would be your bladder or your rectum, perhaps. So there is value to doing what we call prehabbing to kind of see if we can optimize some of those things with your breathing mechanics and the pressure system and your posture and all of these types of things, but also to maybe focus in on some pelvic floor specific training to get the core synergy kind of working as optimally as possible. So you get the best value and the best outcome of that surgery and not have to go back for another surgery 5 or 10 years later because you haven't really addressed what the underlying issue actually is in the first place. So that's the first thing I would say about having surgery and prehabbing before that. But the other thing also is that it might actually help you to prevent you from developing other issues. So once we kind of fix the prolapse, all of a sudden these people sometimes become incontinent because, again, we're still leaking, just maybe not in the form of organs anymore. Now you're leaking in the form of incontinence and urine. So if you kind of go through that process and kind of go through a prehab process, you might be able to kind of be able to hold off on having some of these other outcomes that are, just as sucky as having prolapse issues. Okay, so that's what I would say about that.
That's the technical term, sucky.
Yeah, sucky.
Alana, do you have anything you wanted to add into that? I realize that we're already past our 45 minutes, but I think we could probably spend a couple more minutes if you have something you want to add into that.
Yeah, so I'm right now in an office from urogynecologists, so I work really closely with surgeons, and they really love when people come in before prehab, we call it, as Uma was saying. But a lot of it is also, I want you to, it's the education of knowing maybe why you had prolapse, but your sister didn't. Like there's some modifiable, we call them risk factors, things in your life you can change. And there's some things in your life you just can't change. Maybe you were born with a certain amount of genetic connective tissue integrity. That's not anything you can really change. So the connective tissue is what's holding everything up from the top. But again, we have to look at, people should be asking you lots of questions. If you're chronically constipated and you're on a toilet all the time pushing, if you're still constipated after you have that beautiful prolapse surgery, you're going to have a recurrence. So it's education and really trying to figure out, again, what may have been the issue for you. So it's that prevention. I make the surgeons look good because I make after that, their patients aren't having as many problems with recurrence because I've educated them on what I want them to do and not to do after their surgery. And it's mostly telling people how to do the things they want to do. I don't like to tell people not to do anything because that's not my job.
Awesome. Thank you. All right. I'm going to ask one more question that I think I saw kind of coming up, and it's kind of just a question around, like, we talked about kind of what treatment looks like, but like how long until you see benefits? Like Alana, you mentioned sometimes you'll see people like for 2 or 3 visits and they're doing remarkably better. Sherry is asking for stress incontinence. So can you give us and I know, again, caveat, we can't say definitively it will be 6 visits over 6 weeks. Like it's not going to be that prescriptive, but can you give us a ballpark? If I have stress incontinence versus urge, do you have an idea like high and low end? Can you share that with us?
And again, like right now we're only addressing incontinence, which I hammer into every doctor that I talk to. That is not all we see. So I can't tell you how long a pelvic floor physiotherapy session is, but it's just a matter of so if we're talking about stress urinary incontinence, that's the coughing, laughing, sneezing. A lot of it, again, is education on how to breathe through certain activities and how to use your body well. Like, what's going on here? So sometimes that can, honestly, I mean, on the low end, sometimes it takes, I saw somebody today for stress urinary incontinence. It was the second time I've seen her, and she's like, I've never leaked again. So that's on the low end, I think. Usually I see people once or twice. But I'd say usually, especially, and it depends. Again, like, is stress urinary incontinence being caused because this person has been tight for so long? Because if that might be a little more intensive, I'll have to see them longer than if they're just weak. Weakness is easy because like that's just a way for me to kind of talk to your brain and wake up these muscles. If you've had pelvic pain or pain with intercourse or pain with ejaculation for years, and then you've had also, you know, a bad fall on your coccyx, and then you've had your tailbone, or you've had chronic low back pain or chronic hip pain, those people generally do take longer. A lot of people will have, like somebody mentioned in the chat, like a stinging, a burning, something in their vulva or on their tissue. Often that's a nerve issue. I always tell people, like, your nerves are kind of coming through your muscles. So your muscles are almost like you're gripping onto a steering wheel, and that steering wheel is the nerve going to all that tissue. So sometimes that may be longer. So it's like, it's such a hard question to answer. But it's a good question to ask somebody when you see them. Like, do you think this is going to be long? And we don't see people. We're not like other physio where you see people every week or 3 times a week. I often won't see people for a few weeks. I'll send them home with something to work on and exercise, and then I'll see them again several weeks later.
Awesome. Uma, do you want to add anything to that, or do you think Alana hit the major buckets?
Yeah, I think just the easiest way to answer that question is that it varies, but I think one thing that you can probably pinpoint is if you've had that issue for a really long time, it's not going to be a quick fix. Early intervention is key. So anyone out there who's developing something new, get it looked at right away, because the faster you pick something up and the faster you get it looked at, the better your outcome is going to be. And so, yeah, that's probably the best we can do to answer that question. Again, we're trying to individualize, right? So it's all about what your individual problem is, how long you've had it, how severe it is, you know, and I guess.
And when you meet your therapist in that first assessment, that is 100% the kind of information that you can expect. Is like, this is what I think, you know, and they'll give you, kind of lay that out for you. So I'm going to hang up there, hold us up there. We've almost gone for just an hour. I have put a screen up for everybody that has various different ways to get in contact with us. I know in the chat that there had been links kind of given to our website as well. And you can see that, I think, at the bottom of my screen. Hopefully it's not hidden out of the way there, but maybe when Susie or Andrea, you guys can drop that in the chat for everybody. But there's lots of different ways to connect with us. There's a telephone line that can kind of help you find the clinic that is closest to you. Some of our physiotherapists are also doing virtual care. So again, if you're not thinking about that internal piece, maybe you just want to meet somebody, tell them about your symptoms, they can take a look at your posture and things like that over a virtual appointment. That's certainly a possibility as well. So you can do that. If you'd rather email, there's that. You can book online on our website as well for many of our sites. So you can definitely do that. And then if you follow us on the different social channels, we do things like this, but then also share different blogs and articles and education pieces and tips and tricks there as well. So please go and follow us on those channels if you are not already. Thank you, Alana and Uma, for sharing your expertise with us. We very much appreciate you taking the time to share this with us and really breaking it down in simple ways for all of us to kind of understand. Thank you also to Susie and Andrea, who are in the background managing the chat. They did a great job trying to answer as many as they could. So thank you to you ladies as well. And thank you to all of our attendees for coming and joining us and giving us an hour of your time in your afternoon or evening to learn a little bit more about your health and things that you can do to kind of help yourself, your friends, your family in this area. So again, watch your email probably early next week for an email with the link to the recording. As I said, we will also be publishing a brief written summary of some of the key takeaways from tonight on our website, and also sharing those on our social channels. So watch out for that, but you will all receive the link directly in your inbox. Thank you very much, everybody. Have a lovely evening and a great long weekend this weekend.